before we go to this particular question, look at this blurred image. Are such blurred, hazy images still used for making a diagnosis? Well, honestly, clinically, they are not used. But as far as your exams are concerned, they are important because this is a image of a HIDA scan. And a HIDA scan has certain specific applications in hepatobiliary imaging. See, this is a female patient presented with severe pain in the epigastrium and the right hypochondriac region. HIDA scan is done, and what is the finding on HIDA scan? The gallbladder is not seen. Here, the gallbladder must be seen on HIDA scan. What is this image? What is seen here? What is not seen? We'll discuss this as we go ahead. Non-visualization of gallbladder suggests what? It suggests acute cholecystitis. It is actually a very simple concept. We'll discuss this as we go ahead. Now see, another different type of image. What do you see here? This dense, flexible tube-like structure is actually an endoscope. The tip of the endoscope is in the ampulla. They have injected contrast and we are able to see the dilated common biliary duct here as well as the pancreatic duct. So what is this technique? This technique is called endoscopic retrograde cholangiopancreaticography, or ERCP, for visualization of the biliary tree. What are the indications of doing it? Remember, any condition that causes obstruction or dilatation of the biliary tree, right? For visualization of biliary tree and pancreatic duct, this is used. We have just seen. So therefore, any condition which causes obstruction or dilatation of the biliary tree and the pancreatic duct, ERCP is used. An alternative to ERCP, which is non-invasive, is called magnetic resonance cholangiopancreaticography. When is each one of them used? Which one is better? We will discuss this as we go ahead. Now before that, let us discuss a very useful concept that we are going to use everywhere in hepatobiliary imaging, and that is multiphasic contrast CT. What is multiphasic? What are these multiple phases? Well, these multiple phases relate to the liver blood supply. How does the liver get its blood supply? See, most of the normal liver parenchyma is supplied blood by the portal vein. A very small contribution comes from the hepatic artery. Now that we know this, see how we actually use this particular concept of dual blood supply of the liver. Just imagine what will happen, right? When we inject contrast intravenously, right, this blood goes from the veins into the heart, into the right side of the heart. From the right side of the heart, it goes to the pulmonary vasculature, left side of the heart. From the left side of the heart, it comes into arteries. So do you realize that the contrast will come first in the hepatic artery, right, which is going to supply a very small amount of the liver parenchyma, very minimal contribution, right? When will the contrast come into the portal vein? Portal vein is formed by the fusion of superior mesenteric vein and the splenic vein. First, the contrast will go into the superior mesenteric artery. From there, it will go into the entire bowel, right? Then it will come into SMV. First, the contrast will go similarly in the splenic artery. From there, it will go in the spleen and then it will come into splenic vein. So it will come into superior mesenteric vein and splenic vein slightly at a later time, and then after that it will come into the portal vein. Do you realize that? So once we inject contrast, we obtain images at certain intervals, and at those intervals, contrast is either in the hepatic artery when it is called arterial phase, it is either in the portal vein at a later stage, it is called as portal venous phase or parenchymal phase. These multiple phases of images that we acquire are called multiphasic contrast CT. So see here, we obtain an arterial phase, parenchymal phase, or a hepatic venous phase. At around 30 seconds from injection of the contrast comes into the artery. So what is this image that you see here? This is an arterial phase image that you are able to see here. Now the arterial phase image, right, is going to help us diagnose a few conditions, and these conditions are basically supplied by the hepatic artery. Yes, is the normal liver parenchyma supplied by the hepatic artery? No, it is supplied mainly by the portal vein we just saw. So what are those conditions which are supplied by the hepatic artery? It is mainly a hepatocellular cancer or a hemangioma, right, within the liver, or even hypervascular metastasis from aggressive tumors, they will be diagnosed on arterial phase. So can you see in this arterial phase, liver is not enhancing, but inside the liver, can you see this lesion which is enhancing, heterogeneously enhancing lesion? This is a hepatocellular cancer. Now, after some time, say after around 60 seconds from injection of the contrast, right, at 30 seconds the contrast was in the artery, then it will go into the bowel, superior mesenteric artery, it will go to the bowel, come to the vein, superior mesenteric vein. Similarly, from splenic artery, it will go to the spleen, come into splenic vein. When the splenic vein and superior mesenteric vein fuse together, the contrast will now come into the portal vein at around 60 seconds. This is called as the parenchymal phase. Here, the normal liver parenchyma will show enhancement, right? But in HCC, which had enhanced in the arterial phase, there will be a washout of contrast. Liver will appear bright. HCC, there will be washout of contrast. HCC will appear dark. So that is a peculiar feature of appearance, how we can actually diagnose it. On hemangioma, on progressive phases, it will fill up with contrast. That is how various diagnosis can be specifically made. Delayed phase or hepatic venous phase is obtained somewhere around 3 to 5 minutes, right? Where from the liver, the contrast will go into the hepatic veins, it will go into the IVC, and any abnormality involving the hepatic veins or IVC, say for example like Budd-Chiari syndrome, will be able to be diagnosed on hepatic venous phase. So these are various phases. Remember, a multiphasic contrast CT is actually the investigation of choice for almost all focal liver lesions. It is also the investigation of choice to differentiate between a primary hepatocellular cancer or a liver metastasis. How do they differ in their appearance? This is something that we will discuss as we go ahead. So it is a very, very important technique, remember. So see, this was a question which was asked. Multiphasic hepatic imaging includes all except, does it include an arterial phase? Yes. Does it include a portal venous phase, also parenchymal phase? Yes. Does it involve a delayed phase or a hepatic venous phase? Yes. Does it involve a capillary phase? No. So capillary phase is not a part of multiphasic hepatic imaging. We have discussed the concept of multiphasic hepatic imaging here. Now, see, this topic of focal liver lesions is actually a treasure trove of clinical scenario based questions. I can simply tell you on each and every slide, a hemangioma looks like this, a HCC looks like this, say a METS look like this. But all these questions will eventually be asked to you very likely in your exam in a clinical scenario based type of question. Similarly, when you look at patients in your hospitals, wards, clinics, you will come across the clinical aspects of these conditions as well. So I have decided to prepare you for this. This is the reason why, we will target to prepare ourselves or get ourselves ready for these situations. We will study them in a clinical scenario based pattern going ahead. Now see here. This is a 35-year-old male, presents with fever spikes, elevated counts. What does it tell us? It tells us that there is evidence of infection. Where is that infection? There is pain in the right hypochondriac region, probably in or around the liver, and he also has jaundice. We do an ultrasound. What do we see on ultrasound? On ultrasound, what is seen basically is that there is a complex cystic lesion which is seen, and inside it you see thick hypoechoic echoes within. So you see thick echoes within it. Is it completely liquefied? Probably not, right? So this is some thick content within it. If you do a contrast enhanced CT as is shown here, can you see that there is enhancement along the wall of this particular lesion? So what is this? This is enhancing like a ring. Why? Because the central area is liquefied. There is inflammation at the periphery. So this is collection of pus within the liver. This is classically a liver abscess. USG is usually the first investigation. Another role that USG usually has is it is used for follow-up to look for liquefaction, of the abscess, whether it is completely liquefied or not. What is the investigation of choice for almost all the focal liver lesions? It is going to be a contrast enhanced CT scan. It will appear as a peripheral ring of enhancement. See, this is the same patient, same clinical history. Look at the appearance here. What do you see? We see a hypodense lesion within the liver, but can you see that there are actually multiple peripherally enhancing locules, isn't it? So this is given a name. This is what is called as the cluster sign. What is cluster sign? Multiple small abscesses come together and form a cluster of abscess, coalesce together. That is called as a cluster sign. This very likely suggests a pyogenic liver abscess. A liver abscess can either be pyogenic abscess or a amoebic abscess. Right, a cluster sign, as we are able to see here, is more likely suggestive of a pyogenic liver abscess, in which it is known that small locules of pus actually coalesce together to form a larger abscess. So this cluster sign is more suggestive of pyogenic liver abscesses. Yes. Now see, a young male with an incidentally detected lesion. What do you see? Within the liver parenchyma here, you see a focal hyperechoic lesion. It is appearing bright. Now on contrast and on CT, look at the arterial phase, it shows peripheral early enhancement. Look at the delayed phase, it is almost completely filled up. So this is called as the blood pool enhancement. Means what? In the initial stages, there is just peripheral nodular discontinuous enhancement. As there is progressive enhancement, or as time passes, as more and more contrast comes in, what happens? This will show a centripetal enhancement pattern. Eventually the entire lesion will be filled up. It is enhancing like the blood, like blood filling within it. Why? Because there's actually blood within it. There are multiple blood vessels within it. So this is what are the features of hemangioma. Right? So hemangioma, remember, is the most common benign lesion of the liver parenchyma. So hemangioma is the most common benign liver lesion. They are usually asymptomatic, right? So sometimes a bright dot of a blood vessel within is maybe seen within it. It is called as the bright dot sign. So this is the features of hemangioma. Now on MRI, because it contains blood, or because it contains fluid or blood within it, within the blood vessels, right? On MRI, on a T2 weighted image, a hemangioma appears extremely bright like this, and this is given a name. This is called as the light bulb appearance. This is called as the light bulb appearance. So light bulb appearance on T2 weighted MRI image, increasing the T2 weightage increases the brightness, right? So this is what is called as the light bulb appearance of hemangioma on T2 weighted MRI images. Yes, now look at this lesion. A 40-year-old male presents with an incidentally detected lesion, but the examiner gives you a clue. What is that clue? An SPIO MRI shows signal loss. This is called super paramagnetic iron oxide MRI. This is a specific application. Also see, technetium labeled sulfur colloid scan also shows uptake. The key here to know is that both these agents, super paramagnetic iron oxide as well as this sulfur colloid, are taken up into cells of reticuloendothelial system. And because they are taken up into cells of reticuloendothelial system, it means that these RES cells or Kupffer cells or puffer cells in the liver are present in this lesion. So what is this lesion? This lesion is a focal nodular hyperplasia. So focal nodular hyperplasia is rich in these Kupffer cells, right, of reticuloendothelial system. Therefore this SPIO MRI is going to be taken up. Therefore this sulfur colloid is going to be taken up. It is usually incidentally detected lesion. This is the clincher. So SPIO MRI and sulfur colloid scan, this is going to be the clincher. Otherwise this is a incidentally detected lesion. Yes. Now look at this. This was asked as a recent question in one of the exams. See, a young female presents with a focal liver lesion, but what is the history? She has been on oral contraceptive pills since 3 years. So if you have a history of a young female on OC pills with a focal liver lesion, OC pills are associated with what focal liver lesion? Yes, OC pills are associated with hepatic adenomas. So these are also incidentally detected. A significant history is OC pills. It enhances on the arterial phase. They have a predilection for intratumoral. So adenomas can show intratumoral hemorrhage occasionally. Intratumoral hemorrhage. So most important for your exam is young female ossipils, focal lesion in liver, it is hepatic adenoma. So this was a question which was asked. Now let us look at another history. See here. Elderly male who is a chronic alcoholic with liver parenchymal disease. This is enough for a diagnosis. Remember, if you see chronic liver parenchymal disease or liver cirrhosis, a focal lesion, remember clinically this is what we follow, a focal liver lesion in a cirrhotic liver. In a cirrhotic liver is what? A focal liver lesion in a cirrhotic liver. Unless proven otherwise, it is hepatocellular cancer. Are there any clues here? Patient is hepatitis B positive, that is a predisposing factor. Patient has jaundice, altered liver function test, elevated alpha fetoprotein, which is a tumor marker for HCC. So what is this? This is hepatocellular cancer. See, hepatocellular cancer we discussed is supplied by the hepatic artery. So on arterial phase, it is showing enhancement. It appears bright as compared to the liver. On a delayed phase or portal venous phase, the liver is enhancing, but we discussed that there will be a washout of contrast from the HCC. Can you see how beautifully now the HCC is actually appearing darker? The HCC is actually appearing darker here as compared to the normal liver parenchyma. Now, this is the most common primary malignant tumor. This is the most common. HCC is the most common primary malignant tumor of the liver, and it has the propensity to invade into the portal vein or hepatic vein. So there could be an intravein tumor thrombus which also enhances. Thrombus may go into the portal vein or into the hepatic vein. So on angiography on HCC, there is an appearance which has been described, which is called as the streaks and thread appearance. So streaks and threads appearance has been described on angiography. So this is all you need to know about hepatocellular cancer. Now see here, a similar appearing heterogeneous tumor in a young male, 25-year-old male, no known illness, non-alcoholic, no hepatitis B, presents with what? A large arterially enhancing liver mass lesion with a central calcified stellate scar. This is a peculiar clincher of a diagnosis. Normal alpha fetoprotein and elevated neurotensin B. Do you realize that every step this is different from HCC? Elderly male, here it is young male. No known illness, there was chronic alcoholism and liver parenchymal disease. There is an arterially enhancing mass with a central calcified stellate scar. This was not present in HCC. Normal alpha fetoprotein, HCC. Alpha fetoprotein is elevated, and here specific elevated neurotensin B, which could be a tumor marker. So what is this? This is a variant of HCC which is called as the fibrolamellar variant of HCC. It is, see, and on non-contrast, it is appearing heterogeneous. There is a central calcified scar on a non-contrast CT there. You can see this calcification in the scar. It is arterially enhancing in a very heterogeneous way. You can see that scar which is not enhancing. So it usually has better prognosis as compared to a normal routine type of HCC. Okay, so this is what is fibrolamellar variant of HCC. Now see, look at this clinical history. 65-year-old male, so elderly male, operated case of CA colon on follow-up, presents with anorexia, generalized weakness, jaundice. When you know that there is a primary cancer that was there and you see multiple liver lesions, what do you think of? You think of metastasis. The most common type of liver metastasis, remember, are hypovascular metastasis. So these metastatic lesions, they enhance less as compared to the normal liver. So look at this portal venous phase. In this liver, look at the enhancement of the normal liver, and as compared to that, look at these dark appearing lesions, multiple ones. Can you see? So they are enhancing less as compared to the normal liver parenchyma. So these are called hypovascular metastasis. This is the commonest appearance of liver mets. When we did a PET scan, multiple of these lesions were showing extremely high metabolic uptake of FDG. That is what is used in PET scan because glucose uptake is high in tumors, right? So they are showing hot spots in this particular area of the deposits, right? So this is how liver metastasis would usually present. Most common primary for liver mets is usually CA colon, as in this particular case. On ultrasound, they sometimes give rise to a bull's eye or a target appearance. These lesions may show a target appearance or a bull's eye appearance. Okay. Now look at this very specific history. 58-year-old male, history of appendiceal mucocele, which means that this patient might have a mucinous tumor of the appendix. It may have a mucinous tumor of the appendix, and these mucinous tumors, if they are malignant, they may entirely spread to the peritoneal cavity, fill up the peritoneal cavity. So the entire peritoneal cavity is filled up with thick gelatinous mucinous ascites, and see what has happened to the liver. This is the liver. Can you believe it? All these deposits are the mucinous ascites which has accumulated everywhere. And very specifically, can you see the liver parenchyma has been eaten away? It has been scalloped like this by these mucinous malignant deposits. So what is this? This is given a very specific name. This is called pseudomyxoma peritonei. It is considered that the primary in almost all cases of pseudomyxoma peritonei is usually an appendiceal mucinous tumor. Remember, treatment is, it has usually poor prognosis. Treatment is usually surgical debulking by removing this mucinous ascites. That is how it is done. Now we have seen liver metastasis, and I told you that most common liver metastasis are usually hypovascular metastasis. So they enhance less as compared to the normal liver, but there are exceptions in which we get liver metastasis which are arterially enhancing. So this is an arterial phase image. You are able to see multiple deposits within the liver parenchyma. They arise from usually aggressive tumors, such as arterial enhancing metastasis arise from what? They arise from aggressive tumors like renal cell carcinoma, like thyroid carcinomas, like neuroendocrine tumors, right? Neuroendocrine tumors like carcinoid tumors. They can arise from choriocarcinoma, melanoma. So these could be the primary tumors when you see arterial enhancing metastasis within the liver parenchyma. Yes. Now look at this clinical scenario. A 42-year-old female presents with intermittent mild right hypochondriac region pain. We have seen this when we discussed ultrasound image interpretation module, isn't it? What do you see here? Right, in this image, this is the liver. This on the undersurface of liver is the gallbladder. And what do you see in the gallbladder? Can you see a hyperechoic area with a dense shadow behind it? A hyperechoic area with a dense shadow behind it is what? This is cholelithiasis, right? Remember that the investigation of choice for cholelithiasis or biliary calculi is ultrasound. What is the concept? The concept is that these calculi have poor calcium content, and therefore if you do an X-ray or even a CT scan, because of the poor calcium content, they may not be seen, and therefore the investigation of choice for biliary calculi, so to say, is ultrasound. These are usually mixed stones. The most common type of stones are usually mixed stones. There is a sign, sometimes there are certain clefts within these stones. This gives rise to the Mercedes-Benz sign, Mercedes-Benz appearance or sign. You know, when you examine these stones, that is the appearance. They can be faceted or laminated as well. Now there is no sign of cholecystitis here. What will happen if there is cholecystitis? All this bile will get turbid. There will be echos. GB wall will get thickened. On CT scan, around the GB there will be fat standing, and patient will have very severe pain. In this patient there is only intermittent mild pain, but patient may have very severe pain in such cases. So look at this history now. The same 42-year-old female presents in a few days with severe right hypochondriac pain. There is fever and elevated counts. These are signs of infection, and there is Murphy's sign positive. What is clinical Murphy's sign? You palpate or you examine the right hypochondriac area, ask the patient to take a deep breath, and then you observe the expression of the patient. There will be a catch in the breath because there is severe pain. The patient will suddenly stop breathing at that point and then exhale. That is called Murphy's sign. Similarly, when we do the ultrasound, we apply the probe pressure here, ask the patient to breathe, and patient suddenly has pain. That is called sonographic Murphy sign positive. Right? If you look at this particular image now, what do you see? As compared to the previous one, right, we see the gallbladder, we see the calculus with the shadow, but now there is sludge in the gallbladder. Look at the wall of the gallbladder wall is edematous. We did a CT, and on CT, the gallbladder was distended. Look around the gallbladder, can you see this hazy, dirty appearance? This suggests fat stranding. So there is infection, inflammation of the GB wall with surrounding fat stranding. This suggests that there is acute cholecystitis. Now, when we started this particular topic discussion, I showed you a very blurred image. That image was an image of HIDA scan. Now, what is HIDA scan? HIDA scan is basically using imino-diacetic acid compound. So that is IDA, imino-diacetic acid compound. When you use it for hepatic imaging, it is called HIDA scan. A very simple concept of this scan is that when you inject this IDA compound intravenously, it goes into the liver. From the liver, it is actively secreted within the bile. That is all that you need to know. So what will happen? Within a few minutes after injection of this IDA compound, from the bloodstream, it will go into the liver, it will come into the bile. So what will happen? The entire biliary tree, so right hepatic duct, left hepatic duct, common hepatic duct, cystic duct, gallbladder, right, and the common biliary duct, all of this will be filled up by this radioactive material, that is imino-diacetic acid compound. So now see what will happen. There is a question which was asked, and that was non-visualization of gallbladder on a HIDA scan is suggestive of what? Non-visualization of gallbladder on a HIDA scan suggests acute cholecystitis. Why? How? See here, what will happen in cholecystitis? Just imagine. Now, what is the most common cause of cholecystitis? Can you tell me? Most common cause of cholecystitis is a gallbladder stone. Where is that stone impacted? That stone is impacted over here. So say for example, there is a stone here. This stone is impacted here. So as a result, there is stasis of the bile. The bile has got infected and there is cholecystitis. Now in this patient, if I do a HIDA scan, what will I see? In this particular patient, the HIDA compound will go from the bloodstream intravenous compartment to the liver. From the liver, it will come into the bile. So what will you see? In bile, it will opacify the right hepatic duct, left hepatic duct, common hepatic duct. It will go into the cystic duct. It will come into the common bile duct. But see, when it comes into the cystic duct, it comes here, but this stone is blocking the gallbladder. So will it be able to go into the gallbladder? No. So will you see the gallbladder? No. And therefore, this finding of non-visualization of gallbladder on a HIDA scan is suggestive of what? Is suggestive of acute cholecystitis. That is the concept. So see, on this particular HIDA scan image, here you were able to see the gallbladder. So in this particular image, right, the biliary tree is opacified. This is the common bile duct. It comes into the duodenum. This is the right and left hepatic ducts. Right here, you are not able to see the gallbladder. This is called as non-visualization of gallbladder. Sometimes, occasionally, though it is not very well seen here, in this liver parenchyma here along the gallbladder, there may be an increased uptake of HIDA compound. That is because of the hyperemia here, because it is surrounding the inflamed portion. This liver parenchyma may have hyperemia. Increased uptake of HIDA compound is seen. This is given a name. This is called as the rim sign. Though it is not very well seen here, there can be an increased uptake along the liver parenchyma which lies along the GB fossa because of hyperemia. This is called rim sign. So this is about the concept of HIDA scan in cholecystitis. Now look at this finding now. This is a 45-year-old female incidentally detected finding. What is the finding? Can you see that on this abdominal X-ray, you are able to see the wall of the gallbladder is calcified, more or less as if it is a ceramic or a porcelain gallbladder. So this is actually called as a porcelain gallbladder. It is usually asymptomatic, characterized by calcification of the wall of the gallbladder. Now one important association is that a porcelain gallbladder can be associated with adenocarcinoma of the gallbladder in the long term, and therefore once we see this finding, usually cholecystectomy is performed for this particular reason. Okay, this is one association of porcelain gallbladder that I want you to know. Now see, A 21-year-old female presents with a triad of abdominal pain, jaundice, and a mass. Abdominal pain, jaundice, and mass is a classic triad. And what do you see on imaging? Now, on this CT and MRCP imaging, what do we see? We see dilated biliary tree. What part of biliary tree is dilated? The part of biliary tree that lies outside the liver, that is the common bile duct, shows a fusiform dilatation like this. So see, the intrahepatic biliary radicals are good. This is the cystic duct. Gallbladder is good, but there is a fusiform dilatation of the common bile duct. This is a congenital malformation or a congenital cystic dilatation of the common bile duct. This is called as choledochal cyst. Right, it affects the biliary tree. Therefore, the investigation of choice here is this investigation, which is MRCP. And ERCP can be done, but it is considered to be the gold standard. It is not practically feasible because it is invasive. So the overall investigation of choice considered is MRCP. What is choledochal cyst? Now, choledochal cyst can be calcified or can be classified, beg your pardon. So, choledochal cyst can be classified into various types, and this classification is called as the Todani classification. Various types. So, type 1, this is how the normal biliary system is, right? The right hepatic duct, left hepatic duct, common hepatic duct, cystic duct, gallbladder, and this is the common bile duct. Now, if only the extrahepatic CBD is fusiform dilated, that is called type 1. If there is a diverticulum coming out of the CBD like this, it is called type 2. So, if there is a diverticulum of the CBD, it is type 2. Now, if there is at the opening of the CBD a cystic dilatation, this is called as a choledocho, means the common bile duct, seal, that is cyst, choledococele. This is called type 3. If there is dilatation of intrahepatic as well as extrahepatic, it is called as type 4, or rather this is rather type 4A. If there is only dilatation of extrahepatic, only extrahepatic, is type 4B. And if there is isolated dilatation of intrahepatic biliary ducts only, it is called type 5. This is also given a name. This is called Caroli's disease. Yes, this is called Caroli's disease, which has a very specific imaging appearance. We are going to study that now. So what is this? This is a focal dilatation of only the extrahepatic portion. So what type this is? This is choledochal cyst type 1. So this is choledochal cyst type 1, fusiform dilatation of the extrahepatic CBD. Right? Now the last type is basically, I said, when there is a dilatation of only the intrahepatic biliary radicals. So see, the intrahepatic biliary radical is dilated right here, and there is a vessel within it, isn't it? This is a portal vein branch. So this is what is called as the central dot sign seen in Caroli's disease. This is called as the central dot sign, which is seen in Caroli's disease, which is nothing but a dilated intrahepatic duct with a central portal vein radical within it. So intrahepatic duct is dilated with a portal vein radical is seen within it. This is called central dot sign. This is the feature of Caroli's disease. Yes. Now for biliary tree imaging, another technique can be used. This is called T-tube cholangiography. What is T-tube cholangiography? See, this is usually done for when the biliary tree has been operated upon. Say, for example, there was a biliary injury which was repaired. There was an anastomosis which was done. So a T-tube, the one end of the T, the stem of the T is outside, right? The one limb of the T goes into the proximal biliary tree. The other end goes into the distal biliary tree. So a few days after surgery, before removing it out, contrast is injected, contrast goes into the biliary tree, we rule out leak of the contrast. There is no leak, this T-tube can be removed. This is called T-tube cholangiography. It is usually done post, insertion of the T-tube, inserted during cholecystectomy or after the biliary tree has been operated upon. Okay. Now come to pancreas imaging. Remember the concept, fluid is friend of ultrasound, air is enemy of ultrasound. So pancreas actually does not contain air, but pancreas is in the retroperitoneum. What is there in front of pancreas? Stomach, colon, which is almost always filled with air. So because of this air, remember, visualization of pancreas becomes very difficult on ultrasound, and therefore ultrasound is not a good modality. So ultrasound is not a good modality for evaluation of pancreas. So for most of the pancreatic conditions, remember, contrast enhanced CT is the investigation of choice. That is the concept for pancreas imaging. Now for the pancreatic duct and the biliary tree, there are two types of imaging modalities that can be used. We started with this. So ERCP is endoscopic retrograde cholangiopancreatography or MR cholangiopancreatography. MRCP has the advantage of being non-invasive. It is fairly accurate, right? It is multiplanar, very good imaging modality. But the advantage of ERCP is that not only it helps in diagnosis, but in many conditions it is therapeutic. If there is an impacted stone, that stone can be retracted, a stent can be kept, right? Dilatation of the ampulla can be done, various treatment modalities can be used, but it is slightly invasive, right? So there's always a battle going on as to which is the investigation of choice. If treatment is not going to be done in the same setting, then usually MRCP is considered to be the investigation of choice. But there is an option of undergoing, doing a corrective procedure like putting in a stent, removal of stone, dilatation, sphincterotomy of the ampulla, then usually ERCP is preferred. Yes, so ERCP is usually considered to be the gold standard for visualization of the biliary tree. Right, now look at this clinical scenario. 55-year-old male, chronic alcoholic, presents with epigastric pain. Now just epigastric pain could be gastritis, but epigastric pain with radiation to the back suggests the involvement of pancreas. Chronic alcoholic, is it a predisposition for pancreatic inflammation? Yes. There is guarding, which is again a sign of inflammation. Elevated serum amylase and lipase will clinch the diagnosis of acute pancreatitis. Now, see here, why is this on imaging acute pancreatitis? History-wise, everything fits. On imaging, see, this is the pancreas. What do you see? We see the pancreas is enlarged, bulky. Look at the surface of the pancreas. The margins of the pancreas are very fuzzy margins. This is fluid collection along the surface of the pancreas. The peripancreatic mesentery is showing significant fat stranding. Margins are irregular. It is fuzzy. It is showing enhancement at this stage, right? We have to look whether there are any non-enhancing areas in the parenchyma that could signify that there is necrosis. So enlarged bulky pancreas with fuzzy margins, right? Fluid collections, fat stranding around it. All these are features of acute pancreatitis. Clinically, these are all very classic features of pancreatitis. On X-ray, traditionally in the olden days, certain signs were described. These include one sign which is called as gasless abdomen. So gasless abdomen is seen in a lot of conditions. One of the most important and commonest one which is seen is acute pancreatitis. Another finding is what is called as the colon cutoff sign. Colon cutoff sign. This happens because of the inflammation that spreads along the phrenicocholic ligament, via the transverse mesocolon. So there's sudden cutoff of the colon at that particular point at the splenic flexure. Another sign which is seen described is called sentinel loop sign. So a bowel loop which is located close to the pancreas usually gets dilated. This is what is called as the sentinel loop sign. So on X-ray findings, on X-ray abdomen, gasless abdomen, colon cutoff sign, sentinel loop sign. So these are signs that have been described. Now how do we assess the severity of pancreas? It is done by pancreatitis. It is done by two ways. One is called Balthazar grading system. This has a little bit of prognostic implication. These names you must know: Balthazar grading system and CT severity index. So CT severity index basically includes the criteria of Balthazar, plus it involves or it mentions or includes the presence or absence of pancreatic necrosis. And therefore, because it involves both of them, it is considered to be slightly better as compared to just Balthazar grading, and it has a better correlation with overall mortality and morbidity in pancreatitis patients. So CT severity index is considered to be better. Now look at this clinical history. Our same patient, which was diagnosed as acute pancreatitis, was treated conservatively for say 2 weeks hospital stay. Patient stabilized, right? Patient was discharged. Now this same patient which had an acute pancreatic episode around 2 months back, so after 2 months now this patient has come by with complaints of what? Complaints of abdominal fullness. Why is there fullness? Well, something causing that fullness. There is vomiting, mild pain in the epigastrium, and what do you see? We did a contrast enhanced CT, and on that CT, we are able to see a lesion in the pancreas. See, this is the pancreas, and in the pancreas there is a fluid density lesion with the wall which is showing some degree of enhancement. So what is this? This is an inflammatory fluid collection within the pancreas. Following the first 4 to 6 weeks, if this fluid collection persists, it is given a specific name. What is that, anyone? This is a complication of acute pancreatitis. This is called as a pancreatic pseudocyst. If this patient continues to have attacks of acute pancreatitis, if suppose there are 4, 6, 8, 10 attacks of acute pancreatitis, what will it get converted into? It will become chronic pancreatitis, and then he has had multiple admissions for acute pancreatitis. There is discomfort. Look at the pancreas. Can you see this diffuse calcifications along the pancreatic parenchyma? In this case, now it is called as a chronic calcific pancreatitis. These calcifications that you see are maybe a combination of intraductal calculi within the pancreatic duct along with the pancreatic parenchymal calcifications. So it can be both intraductal calculi as well as pancreatic parenchymal calcifications. Questions are asked. What is investigation of choice for chronic calcific pancreatitis? It is usually considered to be MRCP with secretin stimulation, so that the pancreatic secretions are secreted, the ducts are well opacified. This is considered to be better, slightly better than a contrast enhanced CT study. Endoscopic ultrasound can also be used to look at the pancreatic duct. Gold standard is considered to be ERCP, because then we are able to look at the duct very well, pancreatic duct very well. So this is about chronic calcific pancreatitis. Now see, an elderly male presents with an incidentally detected mass within the pancreas, with or without jaundice. So you see a big heterogeneous mass in the pancreas. Do you see it is appearing hypodense, or it enhances less? So this mass is, this is a contrast enhanced CT, this is a contrast enhanced MR, and the lesion is enhancing less as compared to the normal pancreas, right? So this is what is suggestive of a pancreatic cancer. Overall investigation of choice for pancreatic cancer is considered to be PET CT, because it helps us in overall staging and the looking at the distant metastasis as well, right? On barium, there are certain signs which are described. Because there is a mass here, it is going to widen the duodenal loop. So this is called as widening of the C-shaped loop of duodenum, widening of the C-shaped loop of duodenum, or this is also given a sign which is called as the reverse 3 sign of Frostberg. Reverse 3 sign of Frostberg, that is because there is a cancer here at the ampulla, right? The duodenum appears, takes a shape like this. So this is called reverse 3 sign of Frostberg, or simply the loop may become widened. Alright, so these are the signs associated with pancreatic cancer. Now see, another sign which is seen in pancreatic cancer is called as the double duct sign, which means because there is a cancer at the ampulla, both the common bile duct as well as the pancreatic duct, both of them are dilated. If both of them are dilated at the same time, then this is what is called as the double duct sign, which suggests pancreatic cancer. There are certain cystic pancreatic cancers. One of them is serous cyst adenoma, the other is mucinous cyst adenoma. Remember, S for serous, S for senior citizens, right? So this is called as a grandmother lesion. M for mucinous, M for mother, so middle-aged, this is a mother lesion, right? So that is the age group. So in elderly patients, there is serous cyst adenoma, middle-aged patients, it is mucinous. Look at the appearance. Now this serous cyst adenoma usually has microcysts or small cysts, and because there are microcysts, this gives rise to a honeycomb or a Swiss cheese appearance, honeycomb or a Swiss cheese appearance. Whereas mucinous tumors, they are macrocytic cystic. So look at this coronal reconstructed CT image here. In the head of pancreas there is a lesion, but can you see there are multiple small cysts which are there within that particular lesion. So these are microcysts, honeycomb Swiss cheese appearance, right? Whereas in mucinous, as you can see here, this is a big cystic lesion. There are some macrocysts within it. So this is called as a mucinous cystadenoma. Now before we conclude with this particular discussion, right, remember what could be the various clinical insights that we carry. So what are the investigation of choice? So investigation of choice for GB calculi or cholecystitis, remember, is ultrasound. I told you GB calculi, poor calcium content, so ultrasound is investigation of choice. Similarly for cholecystitis, which is caused as a complication of GB calculi, also ultrasound is investigation of choice. For most of the focal liver lesions, the investigation of choice is multi-phasic contrast enhanced CT. Again, to distinguish between a primary HCC versus a METS, the investigation of choice is same, a multi-phasic contrast enhanced CT. If you want to detect liver metastasis with a known primary tumor, say CA colon, then the investigation becomes PET CT. Detection of metastasis anywhere in the body can be done by doing just a PET scan, right? So it involves the entire body. Metastases are very well depicted. Gold standard investigation for detecting the biliary tree is an invasive procedure called ERCP. Because it is invasive, endoscopic, it is the gold standard, most definitive, but it cannot be done in all cases. So therefore, the best non-invasive investigation for biliary tree evaluation is MRCP, magnetic resonance cholangiopancreatography. Yes. Now see, there are focal hepatic lesions. Let us quickly have a look at them. Let us match the following. So a cirrhotic liver with a focal liver mass and an elevated alpha fetoprotein we have seen. Any mass in a cirrhotic liver is HCC, I told you, right? Elevated alpha fetoprotein also fits. So this is going to be HCC. Young male with a large liver mass, right? With normal AFP, central calcified stellate scar, this could be fibrolamellar HCC. Multiple hypodense or hypoenhancing lesions within the liver is very characteristic feature of liver metastasis. Young female on oral contraceptive pills with a focal mass lesion. What is the liver tumor associated with OCPs? It is hepatic adenoma. We have discussed this. And light bulb sign on MRI is seen in hemangiomas. So light bulb sign is a feature of hemangiomas. Yes. Now, what is the most common benign liver tumor? We have discussed this. Most common benign liver tumor is a hemangioma. Second most common benign liver tumor, remember, is a focal nodular hyperplasia. In focal nodular hyperplasia, if you remember, I have told you SPIO MRI, super paramagnetic ion oxide, and sulfur colloid is taken up because reticuloendothelial cells are present, puffer cells are present. Most common malignant tumor of the liver overall, remember, are metastasis. Most common malignant tumor of the liver overall are metastasis. Most common primary liver malignancy, however, is HCC, hepatocellular cancer, and most common primary liver tumor in children is hepatoblastoma. It is seen in the childhood age group. Okay, so some focal liver lesion insights. We come back to this particular question. HIDA scan, we have studied the concept of HIDA scan if you remember. So 35-year-old female presented with fever, severe pain in epigastrium, right hypochondriac region, right? So these are signs of pain in the right upper quadrant. HIDA scan shows non-visualization of GB. Non-visualization of GB on a HIDA scan suggests what? It suggests acute cholecystitis. That is the answer in this particular question. This technique may be best used for all of the following except what is this technique? It is ERCP. We have studied it is gold standard for biliary tree evaluation, isn't it? Now see, can it be used for a periampullary mass? Remember, it can be used for any condition which affects the biliary tree in the form of obstruction or dilatation of the biliary tree. Can a periampullary mass cause biliary obstruction? Yes, pancreatic duct obstruction, biliary obstruction, double duct sign we have seen in periampullary CA head of pancreas. Unexplained jaundice can be due to biliary obstruction, biliary tree involvement, yes. Recurrent pancreatitis could be an abnormality of the pancreatic duct like pancreas divisum. Anything that affects the pancreatic duct, biliary tree, ERCP will help. Acute pancreatitis without choledocholithiasis. Choledocholithiasis means CBD calculus. Now, if there was a CBD calculus causing acute pancreatitis, then ERCP would help, because then we could actually retrieve that calculus, put in a stent, do a sphincterotomy, so that all the secretions will be drained out and inflammation will subside. But if alcoholism is the cause of pancreatitis, there is no choledocholithiasis, what is the role of ERCP? There is no role of ERCP, and therefore this is the answer in this particular question. Yes? Well, friends, we have considered a lot of clinical scenario-based questions here, isn't it? This is a sort of repetition of what we have discussed in CT imaging interpretation module as well. But here, my intention is to prepare you for all those clinical-based questions. We have used the clinchers or history pointers that were available in the patient's history, merged them with the imaging findings, and that is a better way to come to a definitive diagnosis. I hope you have loved this discussion.